This video will cover bipolar disorder. If there's little known about schizophrenia, unfortunately, there is even less known about the pathophysiology of bipolar disorder. Bipolar disorder is a lifelong and often severe cyclic mood disorder characterized by recurrent fluctuations in mood, energy, and behavior. These vacillate from sad and hopelessness or symptoms of depression on one end to elevated and excited or symptoms of mania on the other end. The US prevalence of bipolar disorder is about 4.5%. About 1% of those individuals have bipolar disorder 1, about 1.1% have bipolar disorder type 2, and about 2.4% have what would be considered subthreshold bipolar disorder, sometimes called cyclothymia. We'll talk about the differences between type 1 and type 2 bipolar disorder on the diagnosis slide. The onset of symptoms in bipolar disorder is typically late adolescence and early adulthood, or usually the late high school, early college years. Over 2/3 of individuals with bipolar disorder do have symptoms before the age of 18, and diagnosis typically occurs in the college age. Bipolar 1 disorder is equally prevalent in men and women, whereas bipolar 2 disorder is more common in women. The etiopathogenesis of bipolar disorder includes changes at the neurodevelopmental level, at the genetic level, the neurobiologic level, as well as contribution of environmental and social factors. It is known that bipolar disorder is heritable and does run in families. However, the specific genetic loci involved in the heritability of bipolar disorder are multifactorial and rather complicated. They involve changes in genes involved with signal transmission, glutamate signaling, hormone regulation, immune function, and histone function. There are also known neurobiologic factors, which include, based on neuroimaging studies, changes to areas of the brain like the amygdala and the prefrontal cortex. Several environmental or social factors, such as early trauma, substance use, certain drugs or medications, and stressful events, can all predispose to the development of bipolar disorder. It is thought that these etiologic changes lead to changes in synapse and circuit function rather than to changes in specific neurotransmitters. These include neuronal changes like hyperexcitability, mitochondrial dysfunction, dendritic spine loss, altered membrane permeability, and ER stress. These eventually lead to circuit level changes like loss of gray matter in the frontotemporal cortices, axonal changes, and dysfunctional emotional processing. These complex disturbances in neuronal circuits then lead to the behavioral and functional expression of bipolar disorder, including mood symptoms, changes in energy level and thought, cognitive impairment, and psychosocial adjustment. It is known that environmental and psychosocial stressors, as well as immunologic factors, can be associated with the development of bipolar disorder. Problems with sleep or sleep dysregulation are also associated with bipolar disorder, and issues with sleep can also negatively influence the prognosis of bipolar disorder once it has already been diagnosed. In general, the pathophysiology of bipolar disorder is largely unknown. The monoamine neurotransmitters serotonin and norepinephrine are thought to be involved, but as I mentioned previously, it is more likely that changes in circuit function rather than changes to the signaling activity of these specific neurotransmitters play a role in this complicated disease state. The diagnosis of bipolar disorder is made exclusively via clinical symptoms using the DSM-5. Shown on the screen are the DSM criteria for mania and hypomania. Bipolar disorder is characterized by episodes of either mania or hypomania, and we'll talk about how these distinguish bipolar 1 from bipolar 2. In general, a manic episode is associated with either irritable or elevated and euphoric mood, as well as increased overall activity. And this persists usually for at least a week, but could be shorter if hospitalization was required in less than 1 week's time. During the manic episode, at least 3 of the following symptoms must be present: inflated self esteem or grandiosity, decreased need for sleep or hyposomnia, more talkative than usual or constant talking or hyperlogia, flight of ideas or experience that thoughts are racing, also known as lack of focus, distractibility, increased goal directed activity, and involvement in high risk pleasurable activities like shopping sprees, sexual indiscretions, or poor business investments. If the underlying mood is only irritable and there is not an elevated or euphoric mood, then 4 of those symptoms must be present. By definition, manic symptoms that last for at least 4 days without an adverse outcome and without causing significant distress to the patient are characterized as hypomania because it's below the threshold for full-blown mania. Bipolar disorder is also notable for episodes or periods of depression. Frequently, depressive episodes may occur before a manic or hypomanic episode, and therefore these patients are often mistakenly diagnosed with major depressive disorder. However, the symptoms of mania are characteristically opposite those of depression. For example, where depression has speech latency or soft speech, mania is characterized by increased, rapid, or loud speech. Where depression normally has insomnia or hypersomnia, mania is characteristic of lack of sleep or lack of need for sleep, also known as hyposomnia. Where depression is more often characterized by psychomotor retardation, mania often has psychomotor agitation. Although not true 100% of the time, the signs and symptoms of mania are typically equal and opposite to those of depression. There are 2 primary types of bipolar disorder, bipolar 1 and bipolar 2. These graphics demonstrate bipolar 1 on the top in panel A and bipolar 2 on the bottom in panel B. Bipolar 1 is characterized by the presence of at least one full-blown manic episode. Usually this is combined with periods of intense depression, although depression is not required for a diagnosis of bipolar 1. Bipolar 2 disorder is characterized by hypomanic episodes rather than full-blown mania. For bipolar 2 disorder, there must be at least one hypomanic episode and a current or past major depressive episode. The hypomanic episode must last at least 4 days, and the depressive episode must last at least 2 weeks. Whereas bipolar 1 can cause significant impairment in social and work functioning, can be associated with psychosis and delusions, and may require hospitalization, bipolar 2 does not typically affect functioning, does not cause psychosis, and usually does not require hospitalization. There is another type of bipolar disorder called cyclothymic disorder. This is characterized by chronic fluctuations between subsyndromal depression and hypomania. It would never reach the level of either hypomania or subthreshold depression, but does fluctuate away from euthymia up and down over time. There are several specifiers of bipolar disorder that are shown on the screen. These include episodes with mixed features, with prominent anxiety or psychosis, with postpartum onset, rapid cycling, or a seasonal pattern. Although we won't talk in great detail about these specifiers, I wanted to present them to you because this may dictate treatment for certain patients. Unfortunately, the prognosis for bipolar disorder includes a reduced quality of life and issues with relationships and employment. Bipolar disorder is frequently associated with drug abuse, anxiety, and suicide. One of the main issues with the prognosis of bipolar disorder is that medication initiation can sometimes be delayed upwards of 8 years from the initial manic episode. Another consideration for individuals with bipolar disorder is that cognitive impairment is a prominent feature, and these cognitive deficits can reduce function and quality of life in individuals who are not properly maintained on a therapeutic for their disease. There is an episode of the Amazon show Modern Love in which the primary character suffers from bipolar depression. I thought this was a really good portrayal of how bipolar depression can affect someone's everyday life and their psychosocial functioning. If you snap a photo of the QR code on the screen, this will take you to information about that specific TV episode that portrays the difficulties associated with living with bipolar depression.